In the decade since the West African Ebola outbreak, there have been numerous proposals and promises to reform global health infrastructure, but global health inequities persist. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Craig Spencer, an emergency medicine physician and an associate professor of the practice of health services policy and practice at the Brown University School of Public Health. Dr. Spencer has written a perspective article about Ebola and other global health threats and the need for action to address inequities. Dr. Spencer, in your perspective article, you describe your own experience being treated for Ebola in 2014. How was your experience different from that of the patients that you were treating in West Africa?
In 2014, I had shown up in Guinea, the eastern part, right around where the outbreak started some months prior. And if people recall, this was a time of a lot of uncertainty. It was a time of increasing cases and a concern about international spread, as well as our inability to really manage the outbreak on the ground in Guinea, Liberia, and Sierra Leone at the time. And I recall going into work many days where we only had a few physicians. There was always the concern that perhaps we ourselves could be infected. I was only there for 6 to 7 weeks. The folks that I was working with, the local Guinean physicians, had been there for 6 or 7 months and were doing this every single day. And it was both physically demanding, but also mentally demanding. And it was made harder by the fact that we didn't have access to a lot of the things that we really wanted. Basic laboratory testing, critical care, any vaccines or drugs, because we didn't have any at that point, as well as the fact that many of us were taking care of 30 to 40 patients every single day, which may not seem like a lot, but when you only have a few hours during each day that you're able to go in with the personal protective equipment to take care of patients, means that you're not able to spend enough time with each individual as you'd like to. Contrast that with my own experience when I fell ill back in the United States and was brought to Bellevue Hospital. There were probably 30 to 40 providers on call at all times for me in the event I needed an x-ray or I needed dialysis. So even at that time, I was grateful that I had lab results back in hours, whereas in Guinea, many of my patients waited for days. I was grateful that I had access to high quality clinical care and that there were multiple medications that were proposed that I take that may have some impact on my course. But throughout this whole time, as I was sitting in a bed in New York City, there was part of me that felt how incredibly unfair this was, how I had just come from Guinea, where I'd seen hundreds and hundreds of patients that didn't have access to really a fraction of what I was getting every single day as I was battling Ebola in a bed in the United States.
Given the attention that was generated by that outbreak, was there hope that it would catalyze changes in our approaches to global health that might advance equity?
There was not only hope, there was a lot of promises. If you recall at the time, there was a lot of criticism around the delay to declare a public health emergency of international concern. And the global community really asked for the World Health Organization to think about how it can do better, but also how the international community could do better in the ensuing years. And out of that process, we got a lot of promises. We got a lot of discussion and a lot of debate around what we can be doing around access to better clinical care, strengthening health systems, not only in West Africa, but in many other places. We got a lot of promises about improving our access to medical countermeasures, making sure that vaccines, drugs, treatments are more available for the people and the places where these diseases, these outbreaks may occur. And there has been some progress in this past decade, but it has been insufficient in comparison to the level and really the magnitude of the promises that were made in the aftermath of the 2014 Ebola outbreak.
Of course, as you say, the inequity remains deeply entrenched. And in your article, you outlined three areas where action's needed. The first is improving access to current medical countermeasures. So why do inequities in access to treatments for Ebola and other infectious diseases persist? And how could those gaps be closed?
My piece is focused really on the past 10 years, but let's be clear, these inequities are not new. We've known of inequities in access to care and treatments going back a really long time. If you think about the experience of plague control in colonial India, or even here in the United States, syphilis and the Tuskegee study that was done. In West Africa, around 100 years before the 2014 Ebola outbreak was first detected, there were colonial sleeping sickness campaigns that basically had a very similar approach to how they treated patients, to how they kind of undermined the agency of local populations that in many ways were copy-pasted 100 years later with our response to Ebola. So these inequities are not new, but the promise of improving them and really the strength of that promise and that commitment is pretty unprecedented. There are a couple things that we can and should be doing, informed by that long past as well as that recent past in global health, to improve access, not just to medical countermeasures, which I largely focus on in this piece, but to critical care, to higher level care, to many other things that are needed in many places to improve outcomes for patients. One of the big things that we need is that right now we have many of these tools. We have access to wonderful vaccines and treatments for Ebola, which we didn't have a decade ago. For Zaire Ebola virus, which was the cause of the 2014 outbreak, when I was taking care of patients in West Africa, in Guinea, we didn't have access to any treatments, nothing with known efficacy to lower mortality. But since then, we've had multiple Ebola vaccines that have received approval, and we've had multiple treatments that have received approval. But I think those treatments in themselves are highlighting how Kafkaesque the state of access to many medical countermeasures really is. Let me take the example of MAB 114, also known as Ibanga. This is a neutralizing monoclonal antibody that was proven in the PALM trial in 2019 to reduce mortality from Ebola virus disease. The treatment is based on an isolate from an Ebola survivor of the 1995 Kikwit outbreak. It was developed through the NIH's intramural research program, and it was approved for use after entirely public funded trials. After its FDA approval, the NIH gave exclusive licensing to a company with no pre-existing production or research and development capacity. As a result, today, it's unclear how many doses of this treatment actually exist. And we think that nearly all of them sit in the United States Strategic National Stockpile. And the result is that the communities that gave the source material for the drug, the communities that hosted the trials, the communities that continue to experience Ebola outbreaks, these same communities lack reliable access to these treatments. So one of the first things that we can do is try to improve access to treatments that already exist. And this can be through the formation of a stockpile for things like Ebola virus treatments. This already exists at the International Coordinating Group on Vaccine Provision for Ebola Vaccines, and we should set up a similar system for Ebola virus treatments so that when outbreaks occur, countries and governments are not reliant on the goodwill of pharmaceutical companies and the US government to send doses, but they can have more reliable, faster access to these treatments from a stockpile that could sit in a place that is a lot more accessible, a lot more rapidly accessible. So one thing is improving access to already existing treatments. We also know that for many other filovirus diseases, including Marburg virus disease and Sudan virus disease, there are no proven treatments. And so what we can hope for is that countries where outbreaks are likely to occur are able to set up a research consortium. There have been over a dozen countries that have experienced filovirus disease outbreaks. And we know that if you're going to do clinical trials to develop these tools, they're going to have to be done in these countries if you're ever going to hope to get enough patients to prove efficacy. As a result, these countries have power. They have the ability to say, we're going to set up a single research protocol across countries where these outbreaks may occur. And in return for hosting these trials, we need some guarantees for post-trial access. We know that in the aftermath of these trials, communities that helped prove the efficacy of these treatments should have reliable access to these same treatments. We've seen how this has been a problem with lenacapavir, which is really a groundbreaking medication for HIV. The PURPOSE 1 and PURPOSE 2 trials showed how it can basically eliminate the risk for new HIV diagnosis for people that are able to receive the twice-yearly injection of lenacapavir. And this is great, but the reality is that even with Gilead coming out and saying that they're going to allow generic manufacturing and make access a lot easier in over 100 countries, many of the countries that hosted the trials to prove the efficacy of this drug are not able or will not be able under this expanded agreement to reliably access it in an affordable and accessible way for many of the populations that were used to trial and prove the efficacy of this medicine. And lastly, we've seen over the past decade that inequitable access to many of the most important treatments or vaccines for diseases like Ebola or Mpox or COVID, they're inequitably distributed across places, across time, and across the populations that need them, largely because they are primarily made in high-income countries. They are primarily purchased by and for populations living in high-income countries, even when many of these diseases are disproportionately impacting people in lower middle-income countries. We've seen over the past few years with COVID vaccines that even with the incredible speed of developing these vaccines, the speed with which they were able to get out to populations around the world was unbelievably slow, painfully and I think morally and ethically unacceptably slow. Regarding COVID vaccines, I had received 2 doses of a COVID vaccine before over 100 countries had received even a single dose. We saw in the first year that COVID vaccines were available, the overwhelming majority of them went to high-income countries. Very few made it to low or middle-income countries. There was a study in Nature that estimated that full vaccine sharing would have prevented over 1 million deaths worldwide by the end of 2021. And in many ways, this vaccine hoarding, giving out boosters for populations that probably didn't have much of a benefit here in the United States before healthcare providers received a single dose in many countries around the world, was not only morally problematic, I think it was self-defeating in that it helped set up the spread of variants like Delta and Omicron that later came to impact us here in the US and many other places. Now, local manufacturing will be important, or geographically diversified manufacturing is going to be important to having agency and having better access. But we can't just copy paste the current mechanism whereby we have large global manufacturers making these vaccines in different places. We need countries and regions to have a greater say in what gets made and how it's able to be distributed. A 2021 article in the New York Times exposed how vaccine doses that were filled and finished, that were completed in South Africa at a time of both vaccine inequity and a high caseload, these doses were being exported to Europe despite their need in the country where they were finished. And so recreating the current global manufacturing system in local places is not going to work. We actually need local ownership. And that is going to involve more than just money. It's going to involve buy-in by countries and by regulators to build up the expertise needed to make sure that there's a market for these medical countermeasures, for vaccines and for treatments that can and should be produced locally. None of these are a given, but the way that we're currently approaching our access to medical countermeasures is absolutely not going to change the current status quo, and it's not going to address the inequities that remain so persistent in global health access.
Do you see the recent action in Rwanda against Marburg virus disease as a hopeful sign? Are there answers there?
Rwanda has shown us what is possible in these outbreaks. We saw how from the time of detection of the Marburg virus to the time that vaccines and treatments made it into the country was unbelievably swift. And really, I hate to use the word unprecedented because very rarely are things so. But I think it was unprecedented, the speed and the scale through which Rwanda was able to mobilize the international community, was able to get in vaccines and treatments so quickly. And it shows that the regulatory environment can be set up. It shows that local actors are able to respond to detect these diseases, but also to coordinate and administer vaccines and treatments in such a short period of time. And in a sense, this kind of blows the cover for a lot of the argument that sometimes these things can't be done or they can't be done so quickly. And for me, this was remarkably personal because one of my best friends was working in Kigali at this time. She had called me to let me know that there looked like there was a viral hemorrhagic fever outbreak. And to be able to, just a few days after that, have recognition and a public declaration of this disease to the international community. And just over a week after that, for her to be receiving an investigational vaccine that is being developed for Marburg, for her to be able to administer an investigational monoclonal treatment that is being investigated for Marburg to one of her colleagues in really just over 7 or 8 days' time is absolutely remarkable and shows what we can and should be doing in the global health space to not only support communities that need this, but to do the trials that are necessary and to make an impact in global health equity. And I just can't say enough about how Rwanda managed this, but also how the international community stepped up to support Rwanda. And I think it really revealed a lot about what we can do in global health equity.
What do you see as the role of global support versus that of in-country investments when it comes to strengthening this local capacity?
Both of these are going to be needed. We're going to need global support because the reality is that it's going to be hard for local production, especially at the beginning, to get set up and to run. You have large global manufacturers that are able to offer products for a lower price based on scale, size, experience, historical markets. So it's going to be difficult for new manufacturers to enter into the market. And there's going to be a period where global support through financing and through other deals and other logistical support is going to be necessary to make sure that they're able to stand on their own 2 feet. But it can't just be global support. There needs to be local buy-in. Countries must be able to set up and stand up the necessary regulatory infrastructure that will be needed. They will need to make sure that there is a well-trained workforce that is able to work in and support local manufacturing in many of these places. These are things that are going to be difficult. And at a time where health spending in many places is decreasing, when there are an increasing number of health threats, if you look over the past decade, we've had at least 6 public health emergencies of international concerns. We're dealing with scarce resources when it comes to global health. And for many places, it may be a hard sell to disproportionately focus those on increasing local manufacturing, the things that may be needed.
So finally, and thinking about that hard sell, what types of global health messages do you think could resonate in high-income countries, given conflicting priorities and political polarization?
I think the most important message is that right now we currently view a lot of the treatments that we publicly fund here in the US and many places as biodefense tools rather than as public health tools. We also need to understand, and it's a bit cliche to say that an outbreak anywhere can be an outbreak here. But the reality is that it's quite true. And as we've seen with the increasing number of public health emergencies and infectious disease threats over the past decade, as well as many other potentially looming on the horizon, the concern about H5N1 and other potential infectious threats. We need to think about how we manage these outbreaks at their source to protect us here. We need to recognize that there's no way that we can wall off the rest of the world. We need to think about how we can coordinate to make sure that people and communities in the places where many of these diseases may originate not only have access to the medical treatments and vaccines that they need, but have access to the surveillance systems, the healthcare workers, the healthcare infrastructure that is needed to help them at the source manage outbreaks and prevent them from spreading any further.
Thank you, Dr. Spencer.